of his grades. And at that time, he was treated with stiripentol and topiramate. And he had some mild developmental delays, and they were in the process of actually weaning the topiramate to try and have him on stiripentol monotherapy. And he'd had a good day the day before he died. Nothing new, really. They'd been to the park playing. His mother put him to bed that night. They were working on helping him to fall asleep on his own and sleep on his own. So he was by himself in his bed. And the next morning when she went to wake him up, he had died. They did attempt to resuscitate him, obviously, but it was not possible. He was in an interesting position. He was, when he was found, he was supine with his kind of bum up and kind of snuggled in with his knees tucked underneath him, as a lot of us have seen little kids sometimes sleep. What's interesting about that to me is that it doesn't seem that he had a generalized tonic-clonic seizure before he died, because that isn't a position someone would be left in following a seizure. So whatever happened to him through the night, he appeared to have resettled himself into a comfortable position before he passed away. This is Olivia. And I didn't know Olivia in life, but I have come to know her sister very, very well, Tamsin Jeffs, who co-founded SUDEP Aware with me, which is an organization to support education regarding sudden unexpected death in epilepsy. And Olivia began having seizures when she was 11 years old. They began as generalized tonic-clonic seizures. She was diagnosed with idiopathic generalized epilepsy, what we called it at that time. She was married. She'd had 2 healthy seizure-free pregnancies and was working full-time. Around the age of 32, her seizures were worsening. She was having generalized tonic-clonic seizures and absence seizures every 1 to 2 months. She was treated with valproic acid, but as many of us know, it can have side effects which lead to poor compliance, particularly in women. And they were in the process of adding levetiracetam to the valproic acid. And she was at work one day. She felt unwell. They had a room where people could go lie down if they didn't feel well at work. And she did go lie down in that room. And when she didn't return to her desk, her colleagues went to check on her and found her dead in that room. Her death was also determined to be sudden unexpected death in epilepsy. And just to round it out, I really want to give you a picture of all the different types of people with epilepsy that can die from SUDEP. I want to tell you briefly about Jordan. I also didn't know Jordan in life, but I've come to know her well through her family. Jordan was a lovely, developmentally normal, excellent student, athlete. She played basketball. She began having seizures at 14 years of age. She had rare convulsive seizures and also rare myoclonic seizures. I think she probably had juvenile myoclonic epilepsy. Most of you would probably agree with me. She was also started on valproic acid, but didn't like the adverse effects and it was changed. She was off that and she was on the Motrigine. We believe she was very compliant with her medications. She definitely did not want to have seizures, particularly when she was playing basketball or at school. So she took her medications. She had a bedroom in the basement of the family home, like teenagers like to do, but she was very reliable. She'd always be kind of the first one up in the morning. She'd be at the kitchen table when her parents came down. And one morning when she wasn't there, her dad went to check on her and found her again in bed, dead. There was evidence in this case that she'd had a seizure from the way the sheets were kind of tousled about and a little bit of discharge on her pillow. So it did appear that she'd had a seizure sometime through the night and had not recovered. So I hope that those 3 examples, as sad as they are and very moving for me, I hope they illustrate for you the spectrum of sudden unexpected death in epilepsy. We do know that people with epilepsy are more likely to die prematurely than the general population. The standardized mortality ratio is 2.3, which means they're 2.3 times more likely to die. The standardized mortality ratio is higher in children. going up to 9 times that of the general population, which really reflects the high mortality among children with significant neurological impairment and the overall low mortality rates, thankfully, among children. And we know that people, when people die prematurely with epilepsy, it's more likely to be an epilepsy-related cause of death than something unrelated to the epilepsy. That might sound obvious to you, but it's possible that people with epilepsy are actually more likely to die, for example, of cancer. But actually, when you look at the data here, they're almost 4 times more likely to die of an epilepsy-related death. And we'll talk a little bit about how to categorize deaths in people with epilepsy. Now, when we consider deaths, and as Tad mentioned, I'm a pediatric epileptologist, so I have had a focus on pediatric SUDEP during my career. When we look at deaths in children with epilepsy, in children specifically with epilepsy, the majority of deaths are not epilepsy related. And this is just data from 4 independent studies demonstrating that the majority of deaths are not epilepsy related. And the most common cause of non-epilepsy related death in children with epilepsy is pneumonia. And that's maybe not surprising if you consider all the complex children with epilepsy, with complex comorbidities and neurologic disability that includes, complex chest disease. Now, it's not true of all the epilepsies. The data that I presented on the previous slide here is kids with all kinds of epilepsy. But if you look at some specific syndromes, like, for example, Dravet syndrome, and I told you off the top about Serenity and Nathan, both children who died of SUDEP who had Dravet. There is data that in Dravet syndrome, for example, the most common causes of death are epilepsy related, those being SUDEP, status epilepticus, and a drowning or a trauma related to a seizure. So I mentioned we'd talk, or I'd try to explain a little bit about how we can think about epilepsy-related deaths. And this is one way of doing so, just thinking about deaths that could be due to an acute symptomatic seizure or status epilepticus. Deaths that are indirectly due to epilepsy, that would be something like an aspiration, dying of an aspiration pneumonia following a seizure where the patient aspirated during the seizure. Dying from things like comorbidities like depression and a death leading to suicide, or iatrogenic effects due to the medications we use for epilepsy. Deaths due to underlying neurologic disease. So children with, or people with brain tumors and strokes also have epilepsy, but you could die of the brain tumor of the stroke, for example, or other neurodegenerative conditions or genetic conditions. And deaths due to epilepsy itself. And there we talk about status epilepticus, although I mentioned above, oh, sorry, I should have said when I was talking about acute symptomatic seizures, those aren't necessarily epilepsy in that case. Those could be seizures in the context of another acute illness like meningitis. But down here, deaths due to epilepsy include deaths due to status epilepticus, deaths due to drowning, traffic accidents, falls, burns, other accidents in the context of a seizure, and SUDEP, sudden unexpected death in epilepsy. So SUDEP itself, for people who haven't reviewed the definition before, this is a definition that's frequently used in our research and sometimes in clinical work as well. The reference below from Lena Nashef and her colleagues in epilepsy in 2011. And they define SUDEP as the death of a person who had epilepsy, which we all know how to define epilepsy, hopefully as recurrent unprovoked seizures, that the death should have been unexpected and occurred suddenly in benign circumstances. The death was not a consequence of trauma, drowning, or documented status epilepticus. It's important to note that death may have been witnessed or unwitnessed. So the 4 deaths that I described to you were essentially unwitnessed, although actually when Serenity died, I didn't tell you her full story, but she died also in bed, was found dead in bed in the morning, but she'd actually been sleeping with her parents overnight. So it was unwitnessed in the sense that no one was watching her at the time, but she was with people at the time, they were asleep. But it's important to note that deaths can be witnessed sometimes, and I do have cases that I'm aware of where people have been with the person when they died. You don't need evidence of a preceding seizure, and some of the cases I told you about, there was evidence and some of there wasn't. And to meet full criteria for SUDEP, the autopsy or postmortem exam should not reveal a cause of death. Now, we work with different categories of SUDEP deaths when we're doing research in this area, because sometimes deaths seem to be SUDEP, but a full autopsy was not performed. And in those cases, we classified them a bit differently, but we still try to study them because, as maybe I'm going to explain to you in a bit, it's hard to find cases of SUDEP. And so if we only rely on cases that very, very clearly meet all these criteria for us to learn about SUDEP, we'll be kind of stuck. So what have we learned? What have I learned? And what has the community learned? Number one, SUDEP is equally common in children. And I already warned you, I'm a pediatric epileptologist and I like to talk about kids. So this is my number one learning point. So published in 2016, I took part in the development of these practice guidelines for the American Academy of Neurology. They asked us to look at the incidence rates and risk factors for SUDEP. And it was a very comprehensive evaluation, as you would expect, on behalf of both the American Academy of Neurology and the American Epilepsy Society. So I'm going to refer to it a little bit in my talk today. And at that time, the group reviewed the incidence of SUDEP in the whole population of epilepsy, all ages, and then in childhood and in adulthood, as shown here on this table on a slide from the AAN. And what you can see is that what we actually found at that time was an almost 10-fold difference in the incidence of SUDEP among children and adults. So these numbers are expressed as rates per 1,000 patient years, and a patient year is one patient living for 1 year with epilepsy. So in adults, the rate was determined to be 1.2 per 1,000 patient years. That means you follow 1,000 patients with epilepsy for 1 year, one will die of SUDEP. The next year you put one back in, follow another 1,000 people, one will die from SUDEP. But the rate determined in childhood was 0.2 per 1,000 years, so almost 10-fold lower. So at the time, I expressed my concern about that, and I wasn't the only one. And my specific reason was that back in 2001, I published in the Journal of Neurology a 10-year retrospective review of SUDEP in children in the province of Ontario. And at that time, I looked through some very old records. I looked through paper records. I asked people for cases. It was in no means was it a population-based study. I knew I had missed cases. And when I submitted this study to the Journal of Neurology, the reviews came back asking me to compute an incidence. And I replied that I was worried about computing an incidence because I knew it would be an underestimation because I knew I hadn't captured all the cases in the province over 10 years. But I did so anyways with a caveat. And if you go back and read the paper, I hope I appropriately noted that I didn't feel that data was population-based. But we had found 27 cases of SUDEP in kids under the age of 18 in Ontario over 10 years, which, doing the math, gave us an incidence of 0.2 per 1,000 patient years, which is the same as what we determined in the 2016 AAN-AES guidelines. So as I explained, I was worried about this because I knew that SUDEP was under-recognized and there was historically poor awareness among coroners and medical examiners. And in fact, the main place that I had found the cases was from the coroner's database. So many years later, I decided to undertake a Canadian Pediatric SUDEP registry. And I know there are some people here today listening who helped me participate in this through our collaborations with the Canadian Pediatric Epilepsy Network. And we did a 24-month data collection through 3 sources listed there: the Canadian Pediatric Epilepsy Network, the Canadian Pediatric Surveillance Program run by the Canadian Pediatric Society, and the Ontario Forensic Pathology Service. Because of that work with the Ontario Forensic Pathology Service, I did have population-based data collection in the province of Ontario. And so we again undertook to calculate an incidence. So at that time, we found 17 SUDEP deaths under the age of 18 over 2 years. And when we worked out the incidence, when we worked out the incidence, we found the incidence in children to be 1.1 per 1,000 per year. So in fact, that is the same as the incidence in children. And here's our number here. But at the same time that we were doing this work, Torbjörn Thompson and his group from Sweden, and they've done some amazing population-based incidence and risk factor work on SUDEP in Sweden, where they have a great source of data. They also found that the incidence in children, in their case, it was under 16 years of age, was 1 per 1,000. So my first lesson learned for this talk today is that SUDEP is more common in children than previously documented. And I now tell people that the incidence is equal in children and adults, and that in all comers with epilepsy, all people with epilepsy, the risk is 1 per 1,000 per year. Number 2, finding SUDEP is difficult. And I already alluded to this a little bit, speaking back to the work that we did publish in 2001. And this has been kind of documented in other ways as well. There was a survey of over 500 US coroners and medical examiners. And this was kind of the first time people tried to look at this in a careful way. Work led by Elson So, who's been a real champion for SUDEP awareness, including during the time that he was president of the American Epilepsy Society. And what Elson and his group found was that even though SUDEP was acknowledged as an entity by pathologists and coroners, they don't use it as a final diagnosis on death certificates and on autopsy reports. And we've tried to come around to understand this better, and I'll speak to that in a moment. But some of that is because it's really important when filling out death certificates and autopsy reports that they have a certain cause of death, or they say it's unascertained. And by definition, SUDEP is a cause of death where the cause of death is unknown. And so it's hard to list that. It's hard for those professionals to, go ahead and list that on an autopsy report or on a death certificate. In addition, it's been shown that there are low autopsy rates in people with epilepsy, sometimes due to lack of family consent. And in some jurisdictions in the US, families actually need to pay for an autopsy, or the jurisdiction needs to pay for the autopsy and the funding is not available. It's also been shown more recently, some work that I was involved with, along with Oren Davinsky, and some work by Owen Middleton, that case definitions are difficult to implement in real world scenarios. So we were aware of this for some of the reasons I described, and we undertook some work with the National Association of Medical Examiners to really hash out how can we change how coroners and medical examiners and forensic pathologists fill out autopsy reports and death certificates, so that we as researchers can later go find SUDEP cases when we want to learn about them. And this paper here on the bottom, this what's called the name position paper, first author Owen Middleton in 2018, really outlines for medical examiners how they can investigate deaths in people with epilepsy so that we can identify cases of SUDEP. And some of that includes just listing epilepsy on the death certificates. We wanted to learn more in our own jurisdiction in Ontario about how deaths in people with epilepsy are recorded on autopsy reports. So we reviewed over 15,000 autopsies undertaken in Ontario, and found 500 in which the people who had died had epilepsy. And we reviewed then those 500 autopsy reports to decide whether they were SUDEP or not. And from that review, excuse me, so from that review, we found 142 cases of SUDEP. And then we looked at how often were the cases of SUDEP as defined by people doing SUDEP research and neurologists actually called SUDEP on the autopsy report. And we found that 75% of these research-defined SUDEP cases were actually attributed to epilepsy, but not SUDEP. So for example, 83 had SUDEP actually listed as cause of death, which was great. And 23, an additional 23 of those 142 had either epilepsy or seizure disorder listed as cause of death. So we can find in Ontario 75% of cases by looking for SUDEP, epilepsy, or seizure disorder as cause of death. We also found that the forensic pathologists who perform the autopsies tend to ascribe an alternative cause of death to other than SUDEP or epilepsy in cases with increased medical complexity or medical comorbidities. And that's not surprising and probably explains why for many years people thought that the peak age of death for SUDEP was 20 to 40 years of age, and that really there was no SUDEP after the age of 40 or 50. And the reason for that is once you get to a certain age, no matter what you die of, if you have an autopsy, they will find evidence of other things that could have killed you, like coronary artery disease, or you may have other comorbidities that could have contributed to death. And that makes it very difficult for a pathologist to call a death SUDEP in someone who had, 75% blocked coronary arteries. So we showed as well in this paper that I was just referring to that calling something definite SUDEP is less likely with older age. And so in these categories where possible SUDEP is much more likely in the older age group, but definite SUDEP is more likely in the younger age group. Number 3, SUDEP really is unexpected. So this is a slide I've been using for a lot of years, and it describes the typical circumstances of death for a person with epilepsy when the death is classified as SUDEP. They're most often found dead in bed in the prone position. Most often the death is not witnessed, and most often there's evidence of a convulsive seizure immediately preceding death. Although I will note that witnessed SUDEP is more common in children, not surprisingly, because as those of us that work in pediatric epilepsy know, parents with children with epilepsy often sleep with their children. So when we talk about the risk factors for SUDEP, again, going back to the 2016 AAN-AES guideline, we did a very comprehensive review of the literature for risk factors. And by far, the most important risk factor for SUDEP, and if you take home one message today, it's to know that the presence and frequency of generalized tonic-clonic seizures is the most important risk factor for SUDEP. And the reason that's so important is because we need to know that when people have ongoing GTCs, that they're increasing their risk of premature death. And if you look here, I find this very powerful. This is the odds ratio for people who have more than 3 generalized tonic-clonic seizures per year. Their chance of dying of SUDEP is 15 times higher, 15 times. Other important risk factors include active epilepsy, so not being seizure-free, not optimizing therapy. There was a really interesting study done by Philippe Rivelin and his colleagues. They looked at a huge number of randomized controlled trials for new epilepsy meds, and they found that the risk of dying of SUDEP, if you're in an RCT, was almost 10 times higher if you were in the add-on placebo group than if you got a good dose and an efficacious dose of the add-on medication. And so what that shows us is that when people are living with medically refractory epilepsy, adding on new meds is an effective way to reduce SUDEP risk. There's also data suggesting that nocturnal supervision is a way of reducing SUDEP risk. So there's studies that have demonstrated that when people share a room or live in a place where they're checked frequently through the night, that they're less likely to die of SUDEP. And some evidence as well that using a nocturnal listening device like a baby monitor reduces risk. And we're going to talk a little bit about how to talk to people about SUDEP, and some of this information is very relevant there. So just go back a sec. So these are what we know about them that are the most well-established risk factors for SUDEP and what we can do to reduce them. But I started this section by saying SUDEP really is unexpected. And all of us who work in this field and work in epilepsy know people who have died of SUDEP who did not meet these criteria. And so these deaths really are unexpected. Through some work with the North American SUDEP Registry, we published 3 cases of sudden unexpected death in people with benign childhood of epilepsy with central temporal spikes or Rolandic epilepsy. We think of this as a benign epilepsy. Many people choose not to treat this epilepsy with medications, but there are these reports of SUDEP in people with less frequent generalized tonic-clonic seizures. Some of the risk in those individuals could be related to the presence of nocturnal seizures, could be that they're not being treated with medication for epilepsy. They could be having seizures we don't know about. And of course, there could be factors we don't understand. We reported on 237 SUDEP deaths from the North American SUDEP Registry. And the biggest take-home message from this work has been, it's written right here, the full spectrum, pardon me, it's in the title, SUDEP in the North American SUDEP Registry, the full spectrum of epilepsies. So it was a little bit more common in men. We had 38% were female. The age range was from 1 to 70, infants to the elderly, with a median age of 26. 40% had generalized epilepsy and 60% had focal epilepsy. And what do we mean by the full spectrum of epilepsies? We think of SUDEP as happening in kids with Dravet or kids with, or people with very severe epilepsy with lots of comorbidities. But only 11% of the deaths reported in the North American SUDEP Registry were in people with intractable epileptic encephalopathies. There were 3 in people with benign epilepsy with central temporal spikes, which I mentioned on the previous slide. And 33% had only had less than 10 lifetime generalized tonic-clonic seizures. And 4% of those who died had never had a reported generalized tonic-clonic seizure. So SUDEP, even though we have these risk factors and we have in our mind the people who are most at risk, we know that it can affect almost anybody with epilepsy. In our pediatric work, and this is work that's been done by Robin Whitney and is in preparation for publication, we have 49 pediatric cases of SUDEP. The male-female ratio is about the same. The median age in this under 18 cohort is 8 years of age. 69% had generalized seizures. 12%, only 12% had focal seizures only. And 19% had focal and generalized seizures. We do have 6 children with Dravet and 4 with West syndrome and 2 with Lennox-Gastaut, but we also have 2 with juvenile myoclonic epilepsy, what's considered to be a more benign condition, obviously. And while you might think these are people who are on, 3, 4, 5 anticonvulsants, in our pediatric data, the majority were on 1 or 2. And we have 7 children who had less than 10 total lifetime GTCs. My last learning point for today, and then hopefully we'll be able to go on and have some questions and some discussion, is this. Number 4, we still aren't talking enough about SUDEP. The people that know me know I feel passionate about this. And Rajesh, one of my hosts today, Rajesh Ramachandran Nair, has been a great advocate and doing work in this area as well. So there's been reports telling us we should be talking about SUDEP. This goes back to, in North America at least, it goes back to 2008, at which time I participated in a task force report from the American Epilepsy Society, which said that we should be discussing the potentially increased risk of death with people with epilepsy as part of comprehensive epilepsy education. The Institute of Medicine report, also US-based in 2012, said, actually took a nice spin on it, and I like this: to manage fears and prevent unnecessary anxiety, people with epilepsy and their families need complete and accurate information about the disorder, and that includes SUDEP. Sometimes we're in a position where we can tell people, I think you're at low risk of SUDEP, and that's helpful. And lastly, the AES recommendations that we've been talking about throughout the talk today said that we should be informing people with epilepsy and parents of children about the risk, and specifically, we should be telling people that seizure freedom, particularly freedom from generalized tonic-clonic seizures, is strongly associated with a decreased risk. Unfortunately, we're probably not doing as recommended. So here I present some work from Dr. Ramachandran Nair and also some work from our North American SUDEP registry. These are from discussions with bereaved relatives. So from the North American SUDEP registry, we found that only 18% of bereaved relatives recalled having had a SUDEP discussion. And of those that didn't recall that, 72% wished it had been discussed. I think it's really important, though, to recognize 10% were happy that it hadn't been discussed with them, and 17% actually weren't sure. So we do need to tailor our discussions appropriately to the audience, to the family. Rajesh's work demonstrated was a little bit more confirmatory. He did some really nice qualitative work speaking with bereaved relatives of people that had died of SUDEP. And he found that all the families wished they had been given more information, and they were really specific. They wanted the SUDEP information to come either at the time of diagnosis or shortly after the time of epilepsy diagnosis. They wanted it delivered in person, and they wanted it from neurologists. So they didn't want to learn about this from advocacy organizations or allied health care practitioners. And I think it's really important that all those groups support families in this journey of learning this information, but they actually wanted to hear the information from the neurologist, from the treating neurologist. And they wanted to hear about risk factors, prevention strategies, and they wanted to hear that in many cases it's rare. We know that people with epilepsy want to know more about their risk. Actually, this is a neat study that was done where they reported on Google searches for the term SUDEP. So they looked from 2004 to 2013, and there was a 5,000 increase over time for the search term epilepsy SUDEP in Google. A study in the UK of parents found that parents of children with epilepsy found that 34% already knew about SUDEP, but 91% wanted to know more. And many years ago, I had the opportunity to hear Nancy Collins, who at a Partners Against Mortality and Epilepsy meeting, talk about why it's ethical to talk to families about SUDEP. That includes the principles of autonomy, where people with patients in healthcare have the ethical right to make decisions about their own care, and to make decisions about your own care, you need to be armed with all the information about your condition. When we don't talk about SUDEP, we're really not telling the truth to our patients, and truth telling is an important ethical principle and establishes a strong relationship between practitioners and patients. When our patients believe we're telling them the truth, we have better relationships with them. The concept of prevention of harm, which is central to how we practice medicine and how we deliver care, is upheld when we tell patients about this risk. And learning about the risks of your condition, of a person's condition, helps over time for them to naturally undergo psychological adaptation to their diagnosis. We were wondering how child neurologists were doing with talking about SUDEP. And so we undertook a survey through the supported by the Child Neurology Foundation through the Child Neurology Society in the US. We surveyed 369 child neurologists, and we found out that most of them are not following the guideline around SUDEP discussion. So only 12% were discussing SUDEP the majority of the time. 36% discussed it half of the time. This is pretty much in keeping with other studies, all shown here on this nice slide of neurologist discussion practices. So we've got data from the UK, North America, South America, Europe, and our Child Neurology Society study here. And the red bars recommend, and these are all surveys of neurologists, just asking them, how often do you talk about SUDEP with your patients with epilepsy? And the red bars is never, and the darker yellow bars are, and the yellow bars are sometimes, and the green is most of the time or all the time. So you can see, mainly it's sometimes. Rarely is it all the time. The other thing we learned from that survey of child neurologists is that their knowledge of SUDEP is quite variable. 40% didn't know the incidence of pediatric SUDEP, 16%, which is low, but still I would prefer, their child neurologists, I prefer they'd all know that the frequency of generalized tonic-clonic seizures is associated with SUDEP risk. The important thing here is that SUDEP knowledge predicts SUDEP discussion. So, and we found this in the work we did, the survey we did through the AAN as well, which is that the more neurologists know about SUDEP, the more likely they are to discuss it. So another thing we found in one of the previous surveys, that if you have lost a patient to SUDEP, you're more likely to discuss it with other patients and families. So this brings me to my my plea for my advocating for people to talk about SUDEP with the people they treat with epilepsy and their families. And I'd like to just outline for you some of the opportunities for SUDEP discussion that we have in our practice. First, and as Rajesh found in his study, is when families want to hear about it, is they actually want to hear about it at diagnosis. And having had a first seizure, I know working with families that parents are terrified. I'm sure it's the same for people that witnessed an adult loved one have a seizure. And a lot of people are actually worried that when they see someone have a convulsive seizure, that the person is going to die. And if families and patients don't ask you if epilepsy is deadly or if they can die from epilepsy, it's often just the elephant in the room, and they're just afraid to actually say the words. So when I am working with a family and they are talking to me about the experience of witnessing their loved one have a seizure, and they don't say, can you die of a seizure, or I was worried they were going to die, I actually say a lot of families tell me that they were worried that their person was going to die from the seizure, and I want to talk to you more about that. Another time, obviously, is when they ask. And we know that clinical practices are busy, and there's not always enough time for families and people with epilepsy to ask the questions they have. But when they do ask, we need to be straightforward with our answers. At times when people are doing better with their epilepsy, and maybe they're in a period of seizure freedom and you're discussing drug weaning or drug discontinuation, that is a time when it's important to talk about the risks of weaning drugs and epilepsy recurring. And at that time, you can talk about SUDEP. The flip side is at times when people are having trouble adhering to treatment. And I know that this can be tricky, but comes up in my own practice with teenagers who are poorly adherent. It's important for people to know that this isn't just about, oh, I don't take my drugs and I have a seizure in gym class, or I lose my driver's license. This is actually about increasing their risk of death. Another important time is the time of lifestyle changes and milestones. So for teenagers, moving out of the family home is an important time because there's going to be a change in how they are reminded to take their meds, and whether they have a roommate and where they're sleeping, and the safety of their environment. That can also be true for the elderly if they lose or anybody who loses a life partner and is now living alone. It can be true for people that are entering into a new relationship, getting married, having children. All those times offer an opportunity. We know that seizures, the more seizures you have, the higher risk you are for SUDEP. And so when we talk to people about having drug-resistant epilepsy or intractable seizures, we can talk about the risk at that time. And really importantly, when we talk about surgical referral, because I know that there can be a lot of hesitation, particularly among adults with epilepsy, to go forward for surgical evaluation. And it's worthwhile to talk about all the risks of epilepsy at the time and what seizure freedom could mean as far as reducing risk of SUDEP. So to summarize what I've reviewed today, I think we've learned a lot about SUDEP since I started doing this in 1999 is when I started. We are making progress. We have initiatives to improve SUDEP case definition. We're using standardized definitions to facilitate quality research. We have well-documented risk factors for SUDEP and clear guidelines for discussion. There are still lots of questions. The most important really is among those with frequent generalized tonic-clonic seizures, what distinguishes when and if a death will occur? Is there a biomarker that can define that high-risk population? If we had a biomarker like that, we could risk stratify when we counsel families and people living with epilepsy. We could apply prevention strategies to those at highest risk and maybe some intervention studies as well. And those biomarkers could act as a surrogate endpoint in clinical trials. And there's some really nice ongoing work I haven't talked about today that is moving that forward. Right now, I think that education is the most accessible tool we have for SUDEP prevention. And I just ask you to talk about SUDEP with your colleagues and with people living with epilepsy and their families. I want to say thank you to the families that have shared their stories with me. There have been so many. Some of my funding is listed on the right side of the slide, and my collaborators and members of my team who have contributed to the studies that I presented today. And here's some pictures of some of the beautiful people who have been lost to SUDEP who have also contributed to my work. And with that, I will hand it back over.
Thank you so much, Elizabeth. And may I request Dr. Kevin Jones to facilitate the question and answer session.
Sure. Hi, Kevin.
Hi, Elizabeth. Thank you. It was fascinating listening to your SUDEP talks. I learn something new every time. We have a whole lot of questions, and I'm going to pick a few themes just to kind of lump things together. One theme that's coming up a lot is the concept of monitoring, whether it's nocturnal seizure monitoring devices or cardiac devices to look for arrhythmias in patients. Want to comment on that?
Yeah, I can. And just before I do that, I have to say that I see that Elaine is a nurse from IWK, and she put in the chat that she knew Nathan and that they've changed their practice. And I thank you so much for sharing that, Elaine.